I want to put it in.
We can just turn off, yeah.
Full screen. Okay, you guys can? Yeah. We're good? Okay. Wow. I'm getting all into my head. So I work at the Maripac Pregnancy and Rheumatic Diseases Clinic as the pregnancy director there, and I'm a clinician scientist at Arthritis Research Canada. Thank you so much for inviting me here. As I was reflecting on my work with BC Lupus Society, I remember 10 years ago, you guys funded me to go and present some of my research studies on lupus as a fellow. So here I am now doing lupus and pregnancy. So why, you guys see this? Oh no, it just shows up online. Okay, so why does this topic matters? As most of you know, lupus affects women more commonly than men. So for every 9 women affected, the ratio is 9 to 1. And most of the lupus presentation is in the childbearing ages. So over 65% of patients present between the ages of 15 to 50. There used to be a lot of fear around pregnancy and lupus, and to the point that some patients were advised not to get pregnant. But our understanding has changed, and we know that it is possible to have a healthy pregnancy in lupus, but it's not a routine pregnancy. So lupus pregnancies are considered to be higher risk, and that's why they need specialized care and monitoring as well as planning. Keep having this. Oh, you guys don't see it, but the bar on Zoom keeps coming up on the middle of my screen. So when is the best time to have a pregnancy in lupus? When lupus is quiet, or in medical jargon, we say when there's clinical quiescence. As I mentioned, risk is higher, but a lot of these risks can be reduced with right preparation, monitoring, and engagement of a multidisciplinary team. And when we condense it, okay, there we go. So what are the different stages? So as I mentioned before pregnancy, we set the foundation, we go over the risk factors, risk and potential risk outcomes associated with the lupus pregnancy. During pregnancy, we follow the patients closely, at least once per trimester, and we pay special attention to fetal health as well. And most of our patients are followed by high-risk obstetrician or maternal fetal medicine. And after delivery, we pay attention to how to prevent flares or manage flares as they come up, and support breastfeeding if that's in line with the patient's plan, and plan for contraception moving forward. So as I mentioned, clinical disease inactivity is important. So we aim for at least 6 to 12 months of disease stability prior to pregnancy. This is especially important if there's history of kidney involvement or lupus nephritis. And the problem is, if patients go into pregnancy with active disease, including active lupus nephritis, the risk of major flare becomes much higher. The risk of their lupus nephritis worsening becomes much higher. So we like to control those before going into pregnancy on pregnancy compatible medications. And so obviously when to wait if the lupus is really active, if there's a recent or new diagnosis of lupus nephritis, or if it's not being controlled well, and if there's severe organ disease. So when I see the patients in the office, I use this analogy that I learned from my mentor. So we talk about green light, yellow light, red light. So green light is a patient has been is on pregnancy compatible medication. They have minimal disease activity or no disease activity, and they've been in that state at least for 6 to 12 months. So we give them the green light. We're like, you have our blessings, go ahead. Yellow light is when the patient has mild disease activity. And this can happen, either for whatever reason, the patient might be in a rush. We don't have time to wait that 6 to 12 months, or the patient shows up to our office with an unplanned pregnancy. So sometimes we use this yellow light analogy, and we say, if there is some disease activity, we can proceed with caution and close monitoring. And then red light is pregnancy right now is not a good idea. And as I mentioned, this is often in the setting of active disease, particularly active lupus nephritis. So why should we not conceive when we're giving the red light? The problem is that active lupus increases risk of major flares during pregnancy, as I mentioned, as well as increases risk of miscarriage, preeclampsia, or hypertension in pregnancy, fetal growth restriction, as well as preterm birth. So preterm birth is like preemie baby born before their due date. The other question that often comes up is, what about fertility? Does my lupus affect my fertility? And the answer is not usually. So lupus directly does not affect the fallopian tubes or the ovaries. However, fertility can be affected by the lupus disease activity or because of some of the medications that we use. And some patients want to proceed with fertility treatment and IVF, and often this is a safe option when lupus is well controlled. So as I mentioned, if patients sometimes find that when their disease is active, they have a higher, lower likelihood of conceiving or harder time getting pregnant, if they have underlying kidney failure or end-stage renal disease. Obviously, as we age, our ovarian reserve can also reduce, and prior treatment with medications, particularly cyclophosphamide. So word about cyclophosphamide. Cyclophosphamide is a powerful immunosuppressant that sometimes we use in treatment of severe lupus, and it can affect ovarian reserve. Ovarian reserve is like the number of eggs that we have that can potentially affect our future ability to conceive. And not every patient that gets cyclophosphamide is not able to get pregnant. So the risk is particularly if the patient has received high doses of cyclophosphamide, so over 7.5 to 10 grams of cyclophosphamide. This day and age, we often use much lower doses of cyclophosphamide, or if at the first exposure of cyclophosphamide, the patient, the woman, is over the age of 30. So sometimes if we're really in a bind and we have to use cyclophosphamide and we don't have other options, we have the discussion with the patient about fertility preservation, or there are some medications that can be given right before giving cyclophosphamide to have cyclophosphamide affect ovaries less. So it's a medication called Lupron. So often the patients are worried that the medications they take can affect their pregnancy or their fetus. So the question is, should I stop my medication? And the answer is always no, definitely not without a plan. And I've said multiple times that active lupus is bad, and active lupus is often, if not always, riskier than pregnancy compatible medication. So we know some of our medications are in fact safe and protective in pregnancy. And any of the changes that, if there are some medications that are unsafe, but we always have to have a plan to transition over those medications to pregnancy compatible medications, or if we're removing the medication, allow some time of disease stability, making sure that the lupus stays inactive without said medication. So what are the medications that are compatible with pregnancy? Hydroxychloroquine. Every lupus pregnant patient should be on hydroxychloroquine. Obviously, there are exceptions to that if somebody has a severe allergy to hydroxychloroquine, or if they've had issues with their eyes and they can't be on hydroxychloroquine. Otherwise, we definitely know that hydroxychloroquine is safe and should be continued in pregnancy. Azathioprine is also safe in pregnancy. Tacrolimus and cyclosporin are safe in pregnancy. Prednisone or prednisolone, they're definitely safe for the baby and they don't cause any birth defects. But as you would know, prednisone in high doses, long-term, comes with its own laundry list of side effects. So whenever possible, we'd like to use the lowest effective dose. And the other problem is when the patient's on really high dose of prednisone, we can't really say the patient's in remission or doesn't have disease activity if they're using high dose of prednisone. So high dose of prednisone is a surrogate marker for ongoing disease activities. NSAID stands for non-steroidal anti-inflammatory medication. So that's like Advil, Aleve, naproxen, Celebrex. They can be used in the first trimester and second trimester to an extent, not too much, but we avoid using them in the third trimester. So what are the medications that are not okay in pregnancy? Yes.
The cyclophosphamide, is
yes.
that not a chemo drug?
It is. Well, yeah, it can. I mean, I don't use it. I don't treat cancer, but yes, it gets used in cancer treatment as well.
And
yeah.
So why would someone use cyclophosphamide?
Yeah. For lupus treatment?
Yes.
Yeah. So it has been used for lupus treatment as well. Before we knew MMF is as effective, we would use cyclophosphamide for lupus nephritis or kidney in the lupus. And if patients have really severe manifestations, if they're bleeding into their lungs or if they have inflammation in the brain, those are also some instances where cyclophosphamide maybe get used in lupus as well. Great questions.
I have a question too on your previous slide. How many years of testing have those drugs been taken over? Because you say that they're compatible, there's no issues or whatever for either the person taking the drug or the.
Yeah, yeah.
So how many years?
Yeah, hydroxychloroquine has been around 40 years, 30 years. It used to be like an anti-malarial drug. Azathioprine, 25, 30 years. The problem is, and this is something that I want everyone to remember, is that pregnant patients or women who are about to get pregnant just automatically get excluded from studies. So you're not going to find a clinical trial of a lupus patient where they by intention included a pregnant patient. And I guess, well, from an ethics perspective, it's if we don't know if a medication is safe in pregnancy or not, the drug companies don't want to carry that on, and we don't want to expose the baby to potentially a harmful medication. But as you can imagine, this creates a void where often medication, we don't know if a medication is safe in pregnancy or not until years after it's been available in the market. I think pediatrics kind of sometimes faces the same problem as well. So a lot of this pregnancy, whether a drug is safe in pregnancy or not, is either patients like at least at the early stages, or patients accidentally got pregnant on a drug and you're like, oh wait, like actually everything turned out fine. Or it's through retrospective data. So we like, for example, the research that we do here in Arthritis Research Canada, we can look at pregnancies over the past 20 years and link moms who've had lupus with babies that they've delivered and look to see what medications they've been and look to see whether those babies had any birth complications. So, yeah.
Case studies.
Well, case studies is like 1 or 2 patients. These are kind of called cohort studies or like, yeah, retrospective studies. So rather than you're starting here and moving forward, you're looking back and you say, okay, let's look at all these women who've gotten pregnant on hydroxychloroquine and delivered. And we've actually compared women who, I'll come back to it later, women with lupus who discontinue their hydroxychloroquine in pregnancy versus women who continue their hydroxychloroquine in pregnancy. Those who discontinue it are more likely to flare. And as I mentioned, when you're more likely to flare, you're more likely to have those adverse pregnancy outcomes like hypertension, preeclampsia, preterm delivery, and babies that are on the smaller side.
Thank you.
Yes.
I just want, as a patient, I've been on hydroxychloroquine for 50 years, so pre-children, and had taken the drug during pregnancy. My son is 40 and my daughter's 38, so you're good.
Excellent. Thank you. That was not planted.
So they haven't been tested for anything. I mean, you say they're good from whose perspective? Right.
Well, they haven't shown any signs of lupus, and it's not supposed to be hereditary, so.
Right, but I mean, does that mean that, I'm not talking about lupus, but anything else? Like, I mean, there could be other side effects not related to arthritis or lupus or whatever, as a consequence of taking a medication. So
Yeah, you don't have to obviously answer that, but I mean, it's hard to know. And like, we don't test people, like if somebody's mom has lupus and their child is born, we don't automatically check the baby for lupus, right? Like there's no point. If yes, the risk of the baby is a little bit higher to somebody whose mom doesn't have lupus, but as you know, there's so many different things have to go wrong in a patient's life or a person's life to develop lupus. So a little bit of genetic risk factor, predisposition, environmental factors, bad luck, and all of these like kind of Swiss cheese holes have to line up for someone to get lupus. But I mean, not hydroxychloroquine, but even our biologics that we use, we know that if somebody continues them throughout pregnancy, regardless of whether they breastfeed or not, the drug will really last in the baby for the first 6 months. So if really nothing happens in the first couple of years, they're fine. Most of the drug exposures in pregnancy, the concern is this drug gonna cause birth defects? So that's what we focus on.
Yeah, because really taking hydroxychloroquine, for example, is to treat the symptom. It's not going to necessarily be passed through the mom to the child to prevent lupus, like lupus.
No, the goal is not to prevent lupus in the
Exactly.
child. The goal is to keep mom's lupus in remission, so the mom doesn't flare in pregnancy, and so the baby is able to, because it's not about just inflammation in the mom, and I use this analogy, like obviously the circulation of the mom and the baby are related and through the placenta, so that inflammation from the mom can affect the baby's growth. So lupus, severe rheumatoid arthritis, systemic inflammation in mom can affect the baby's growth. Just for the sake of time, maybe I'll move along. I only have 4 minutes. So the medications that are not safe are mycophenolate. The other name that it's known by is Cellcept. We have to be off of this drug at least for 6 weeks, but we actually aim for 6 months. So this is a drug that's commonly used in lupus nephritis. And if a patient who's had lupus nephritis needs to transition off mycophenolate, they usually go to azathioprine. Similarly with methotrexate, again, we have to be off of it at least for 1 month, preferably 3 months. But again, if somebody's been on methotrexate and I'm removing the drug, I either want to replace it with another drug, or I want to make sure that the patient's disease activity remains good off of the drug. So again, looking for that 6 months, cyclophosphamide, at least 3 months. Leflunomide is a tricky one. We used to think it's really bad, again, because like it caused some problems in mice. But as we learn more about the drug, we don't use it in pregnancy, but if someone happens to get pregnant on it, it's not like the end all be all. And we can do something called the leflunomide washout, and most of these babies have turned out fine. Okay, so again, these are not bad medications. They're not just pregnancy medications, and we have to use safe alternatives. Aren't you just loving my slides? I'm using your system. I know. I'm loving them myself. So again, why is hydroxychloroquine so good? As I mentioned, it reduces flare risk. It's associated with better outcomes in pregnancy, and it's safe before, during, and after pregnancy. And it can also help us prevent something called heart block, which I'll talk about in a second. So yeah, what is heart block? Heart block happens because of presence of antibodies in the maternal circulation or in the mom. So the antibodies are SSA and SSB. And then the other antibodies we carry in pregnancy are antiphospholipid antibodies, and these antibodies can increase risk of miscarriage and clotting. So there are 3 types of antiphospholipid antibodies. In order for someone to be called, they have positive antiphospholipid antibodies. They have to have the antibodies test positive on 2 occasions, 3 months apart. But if somebody has antiphospholipid antibodies, they are at higher risk of having miscarriages, preeclampsia, growth restriction, and blood clot either during or even after pregnancy. These Rho and Law antibodies, or SSA or SSB antibodies, they can be present in up to 40% of patients with lupus. And if those patients get pregnant, there's a 1 to 2% chance of having heart block in the baby. And this is regardless of whether these antibodies cause symptoms for the mom. So these are antibodies we also see in another disease called Sjogren's syndrome or Sjogren's disease, and they can cause dry eyes or dry mouth. But even if mom doesn't have symptoms of Sjogren's, dry eyes, dry mouth, they can pass the antibodies across the placenta to the baby. And as I mentioned, 1 to 2% risk of heart block. However, if the mom has had previously affected children, for the next pregnancy, the risk goes up to 17%. But again, we know that hydroxychloroquine can be protective. And for moms who have had previously affected children, if they're on the second pregnancy, they're on hydroxychloroquine, that risk from 17% drops down to 7 to 8%. The period of risk for heart block is between 16 to 26 weeks. So in that period, the mom is under more intense surveillance, and we listen to the baby's heart rate once a week. So just wanted to give you some numbers. What are the risk of lupus flare in pregnancy? It's a pretty wide range, as you can see, 2.5 to 35%. And again, that reflects that individual risk. when was the last time the patient had their flare, what medications they're on. Preeclampsia in the general population is around 5%. In lupus in lupus patients or pregnancies, it's been reported anywhere between 6 to 25%. Fetal growth restriction, about 5% in lupus pregnancies, small for gestational age infants, around 25%, preterm around 31% in lupus patients compared to 10% in the general population. Again, these are averages and the individual risk can vary. Oh dear. Just a couple minutes, I'm almost done. I've already talked about this. So who's at higher risk? Patients who have high disease activity and patients who have antiphospholipid antibodies. And if the patient has underlying significant kidney disease, heart or lung disease, or pre-existing hypertension, that also heightens their risk. So what's in our toolkit? Hydroxychloroquine for everyone. Most patients with lupus during pregnancy also get started on a baby aspirin, and this has been shown to reduce risk of hypertension in pregnancy. For patients who've had antiphospholipid antibody syndrome, they are also on daily injection with heparin to reduce risk of clotting. We do blood pressure monitoring, especially in the third trimester. A lot of these pregnancies get monthly growth scans after 20 weeks and fetal heart monitoring if if the mom has SSA antibodies. So if you end up in our clinic, we usually have a visit before pregnancy. We go through your disease and what manifestations you've had, what medications you've tried, failed, what's worked, what hasn't, what are the antibodies that you have, and then you'll be given a green, yellow, red light. If it's a red light, we'll work towards obviously a green light. During pregnancy, we see you in pregnancy at least once per trimester, doing blood work, urine testing, especially if the patient has had lupus nephritis. Do not do fetal growth ultrasounds, but I'll refer you to somebody who can. And then again, after delivery, monitoring for flare and reviewing to make sure the patient is on breastfeeding compatible medication if that's something they wish to do. I don't want to talk too much about this, but lupus flare and preeclampsia can look similar, and we have some ways of telling them apart. Postpartum, again, especially the first few months with that like hormonal crash, some patients do experience more aches and pains and flares. So we pay special attention to that. Obviously, on top of that, most patients are sleep deprived. There's increased stressors in their life. For patients who have antiphospholipid antibody syndrome, they need to continue that daily injections, usually for another 6 weeks postpartum. We make sure that if the patient wishes to breastfeed, they're on pregnancy compatible medications. Hydroxychloroquine, azathioprine, tacrolimus, prednisone, and NSAIDs are compatible with breastfeeding. And then in the postpartum visit, we want to talk about your next pregnancy if that's what you wish to do. So making sure that patients are on appropriate contraception. IUDs are safe in all lupus patients. Yes, IUDs are safe in all lupus patients. There are 2 types of IUDs. We can talk about that. That's not the point of this talk. If the patient has positive antiphospholipid antibodies, we avoid estrogen-containing contraception, and they can use progestin-only options. But Plan B is okay for everybody in case of an accidental oopsie. So what are our 5 take-home messages? Pregnancy with lupus is possible. Plan early. Sometimes I joke with my patients that even before your husband or your family, I should know so we can plan for it. We aim to make sure that the disease is quiet at least for 6 to 12 months. Do not stop your medication without talking to your team. And in the postpartum period, we pay as much attention as and planning as during pregnancy as well. So again, our goal is not just a healthy baby. We want a healthy mom and healthy baby. That's my last slide. Okay, thank you.